The following podcast is part of a certified educational activity titled Chair's Take, Latest and Emerging Evidence of PARP Inhibitors in Ovarian Cancer Management. Access the entire activity and complete the post-test at peerview.com/VSY860. Downloadable slides and practice aids are also available.
Greetings and welcome. My name is Brad Monk. I'm a gynecologic oncologist from Phoenix, Arizona, where I am professor within the University of Arizona as well as Creighton, again both here in Phoenix and also part of the U.S. Oncology Network. This is Chair's Take. Latest and emerging evidence of PARP inhibitors in ovarian cancer management. Our times are changing. It's very difficult to keep up, I get it. It's like drinking from a fire hydrant, but it's good for patients. New agents, new indications, and new opportunities, again, for patients, which is what we care about. This landscape here is the 9 FDA approvals. Very, very exciting. We've been in this landscape since 2014. Most importantly, I'm going to talk to you about the 2 on the right, the 2 frontline indications that have now happened in 2020. These are practice changing, and it's very exciting, again, for patients. And I'm going to talk about the one study which is called PRIMA, niraparib, and the other study which is PAOLA-1, olaparib, and bevacizumab. So these are the approvals. I wanted to provide this sort of granularity for you. I get it that there's a lot of details here, but details matter because it's those details that led to the approval, and it's those approvals that lead to the reimbursement and lead to the NCCN recommendations, which we'll touch upon briefly. So we have 3 PARP inhibitors in the ovarian cancer clinic. We also have one that's just approved in breast cancer, talazoparib. We're not going to talk about that, but it's very exciting. I think you probably saw the 2 recent indications in prostate cancer. We also have a PARP inhibitor in pancreatic cancer. So we have 4 tumor types where PARP inhibitors really have been transformational. I'm going to talk to you today here briefly about ovarian cancer and summarize the recent results of the ASCO meeting, which was also held virtually, and also some indications and publications that came from the Society of Gynecologic Oncology. So by way of introduction, as you know, PARP inhibitors inhibit single-stranded DNA repair. And when a single-stranded DNA break goes unrepaired because of a PARP inhibitor, the cells have double-stranded DNA breaks, which we can measure, and we'll talk about that. And if a double-stranded break is unrepaired, then the cell dies. And the primary mechanism for double-stranded DNA repair is homologous recombination, where one sister chromatid is lined up to the homolog and repaired. Homologous recombination, okay? One of the first discoveries, though, is that was really important is the BRCA gene was the dominant way of homologous recombination. But early on, we knew that there were other mutations beyond BRCA that were biomarkers for PARP sensitivity. We also learned, as shown in this slide, that not only was there activity beyond BRCA mutated tumors, but platinum sensitivity also correlated with activity. Again, platinum causes platinum adducts, breaks the DNA, and if a cell can't repair that platinum-induced DNA damage, the cell also won't be able to repair the PARP inhibitor-induced DNA damage. So even platinum sensitivity was a clinical biomarker. So we had molecular biomarkers and clinical biomarkers. And that launched a number of these maintenance trials in recurrent cancer, which are more historical. So if a patient had a second-line platinum doublet, responded, the biomarker then was there, and regardless of molecular signature could pivot to maintenance. And people would say, come on, it's really treatment. You're right. It's both maintenance and treatment. So you hear me use that word, maintenance treatment. So Study 19 and Solo 2 provided that opportunity for olaparib, NOVA for niraparib, and Ariel 3 for rucaparib. So interestingly, based on this, immediately we had 3 indications, not immediately, but now today, 3 indications which are identical. Platinum-sensitive responders, maintenance PARP inhibitor, olaparib, niraparib, and rucaparib, which created a lot of challenge because not only did you have to understand the indication, but you had to pick the agent. So we've had lots of conversation about the differences between these PARP inhibitors because they are not the same. They're not the same, just like docetaxel and paclitaxel and nab-paclitaxel are not the same. I get it that they're all taxanes. Oxaliplatin, carboplatin, cisplatin, all platinum, but they're not the same. So I think the responsibility on us is to really begin to differentiate the molecules so that we can use the right medication for the right patient at the right time. So this slide summarizes sort of the differences in the hazard ratios. I show you that without maintenance treatment, that these patients recur in 4 to 5 months. Surprisingly consistent. But when you add a PARP inhibitor, they can have statistically significant, clinically important improvements in progression-free survival. And all of these papers basically were published in Lancet or the New England Journal. So very transformational, led to 3 indications. Our critics would say, come on, Brad, really? Those are just prolongations and progression-free. I'd say, yeah, that's right. But they'd say, but the patient needs a holiday. And I'd say, yeah, that's right. But the reality of all of those indications did not show a decrement in health-related quality of life. So not only is it a holiday from the medication, chemotherapy, but it is a holiday from disease-related symptoms. So you get both. And I'm not going to talk a lot about the adverse reactions. Again, we've been into this life cycle for more than 5 years. But the side effect profile for the PARP inhibitors are different. The doses are different. Even the schedules are different. One is once a day, the other are twice a day. And we'll talk about that in the panel discussion, is how one differentiates one PARP inhibitor from another, not just on activity, but also adverse reactions. So now at ASCO, for the first time, SOLO 2, not only did we have an improvement in progression-free survival, but overall survival. Transformational. And not a little one. Okay? More than a year. So this really adds confidence to the idea that when a patient responds to second-line platinum, they need a PARP inhibitor for maintenance, and that those patients can actually not only live longer, but I would argue live better. So they even did a fancy analysis adjusting for crossover, but even with crossover, there was still a statistically significant and clinically important difference. But when you adjusted for crossover, then obviously it got better. So that's great. That's in recurrence, 3 indications, but what about frontline? We have now 2 single-agent frontline indications. The first was, again, sensational, published in the New England Journal, but it was only for germline and somatic BRCA. That's called SOLO 1. PRIMA, though, is beyond BRCA, also published in the New England Journal. So these are very impactful, peer review, externally validated endpoints by the FDA, and very exciting. So I think all of you are probably familiar with SOLO 1, hazard ratio of 0.30, again, only in BRCA mutated frontline patients with a 3-year improvement in progression-free survival. Transformational. But it was a limited subset. It was only patients with germline and somatic BRCA mutations. So we wanted more. I wanted more. And so the first trial was a GOG trial, if you didn't know, and I co-direct the GOG with Rob Coleman. It's our pleasure. And obviously our chief is Larry Copeland. So SOLO 1 was a GOG trial. This next study, Beyond BRCA, was also a GOG trial, but we partnered with the Europeans. We made this a global opportunity beyond BRCA. And in fact, the first author of PRIMA is Gonzalez Martin, who is from Spain. I'm the last author. So there are a number of endpoints. This slide shows the different endpoints. Progression-free survival is the primary endpoint. At the meetings, I'm going to show you there's the PFS2, and overall survival is not yet mature. But this is frontline beyond BRCA. SOLO 1 BRCA alone, PRIMA beyond BRCA. And it met its primary endpoint of HRD, hazard ratio of 0.43, doubled the progression-free survival, a no-brainer. HRD, again, is the molecular signature for BRCA-like, okay? It is a genomic scar. Again, if you can't repair double-strand DNA breaks, PARP inhibitors work. And if you can't repair them, the genome is scarred, and you can analyze that, which a test that I'll talk a little bit about later, but it's a Myriad MyChoice HRD, and I'll get into that later. Not only did it work in the homologous recombination deficient primary endpoint group, but in all comers. And all comers had a hazard ratio of 0.62. So really transformational. Obviously, as I said, published in the New England Journal, and the endpoint was blinded independent central radiology review, so again, externally validated. A very impactful and amazing opportunity, which led to FDA approval on April 29th. I presented at the Society of Gynecologic Oncology the BRCA1 and BRCA2 data. The reason this is important because, as you know, BRCA1 is more pathogenic. It's harder to treat. It's more dangerous. As you know, a patient who has a germline BRCA1 mutation has a higher risk of breast and ovarian cancer. So the point of this is that it worked, very similarly in the hardest to treat subset in the BRCA1 patients. Again, BRCA2 patients are more responsive. And it even worked in the patients without a molecular signature in what we call homologous recombination proficient, or HRP. So it has a broad label. You see on the right side of this screen that really it doesn't work that well in the HRP subset, but it may be the only opportunity that patient will have to have a PARP inhibitor as per an FDA-approved indication. So even though it doesn't really feel that good, there are some patients that do have substantial benefit, even in the HRP subset. And you can use Bevacizumab later, right? So the idea is that every patient really with ovarian cancer should be considered for a PARP inhibitor and Bevacizumab, okay? So that's an important distinction. So Prima was the first once daily PARP inhibitor, the first study to have beyond BRCA. And we even changed the dose here. It's the only PARP inhibitor with a personalized dose. The dose is lower if the patient is small or has a low baseline platelet count. So if they're less than 77 kilograms, or either one, less than 150,000 baseline platelet count, they should be started at 200 rather than 300. And again, importantly, with our European colleagues, this study was FDA approved 37 months after the first patient was enrolled. We changed the landscape and the treatment of newly diagnosed advanced ovarian cancer in just over 3 years. In fact, it was approved 2 months before the PDUFA date. So other endpoints are developing, again, not quite mature. We're very interested in the overall survival. Again, we just really can't make a statement, but it's very interesting that in the HRP subset, we're in the right direction. You can see clear separation. So again, this was a big day for our patients. April 29th, maintenance treatment of patients with advanced epithelial ovarian cancer, which includes tubal and peritoneal, if they respond to frontline chemotherapy. So you can look at it as sort of an extension of chemotherapy, but without a decrement in quality of life. So we like that, but maybe we should do combinations, right? So I said that every patient should be considered for Bevacizumab and a PARP inhibitor. Why not both? Good idea, right? So while we were doing Prima in the US and Europe, most of Europe was actually doing this PALA-1 study because, as you know, Bevacizumab was approved in Europe in 2011. We needed to work with the FDA to help them understand the value of progression-free survival. And once the FDA sort of bought into the PFS endpoint, we were able to get Bevacizumab approved in June of 2018. So many of us actually like PARP inhibitors, SOLA-1, BRCA, Prima, beyond BRCA, but we also like combinations. And so now we have to consider sort of a single agent versus a combination. So PALA-1 is a large phase 3 trial, also published in the New England Journal in the same issue as Prima. Ovario is a small study with niraparib. And then in platinum sensitive relapse, GY004 was an oral anti-VEGF cediranib. So PALA-1 was approved on May 8th, but only in the HRD subset. So you see that on the left. Again, a hazard ratio of 0.33, very transformational, with a median in the combination group of 37.2 months. Think of that. Half of your patients can have a progression-free survival longer than 3 years. So what you do, you start bevacizumab frontline, and if the patient tolerates it and responds to that plus chemotherapy, after 6 cycles, then you can layer on olaparib in the maintenance setting if the patient has this HRD molecular signature. It also works, very well in the BRCA patients. So many of us would actually prefer, if she is BRCA mutated and on bevacizumab, to layer on the olaparib rather than to stop the bevacizumab and give her olaparib alone. Again, not approved in HRP. So it did meet its endpoint of intent to treat analysis, and you see that here, but that is not the approval. So this is the entire PALA-1 population. Again, met its primary endpoint, also published in the New England Journal with PRIMA. But this was not the indication, at least by the FDA. It'll be interesting to see what Europe says, whether it's an intent to treat analysis approval by the EMA. That's not what the FDA said. The FDA approval for bevacizumab olaparib is only in the HRD subset. But HRD expands the opportunity beyond BRCA still. It really almost doubles the opportunity, almost 50% of the patients. And again, this is now good for patients. On May 8th, they can not only have bevacizumab or PARP, now they can have both, again with the 37-month progression-free survival at the median. This is an update of that, the BRCA1 and 2 subsets. There's a lot of conversation that if the patient was on is on bevacizumab and gets a germline or somatic BRCA mutation, should you stop the bevacizumab and just give olaparib or niraparib as per the indications, a la SOLO-1 or PRIMA, or is the combination the better option? In other words, keep her on the bevacizumab if she has a BRCA mutation. So this was presented at ASCO, both the BRCA1 and BRCA2 subgroups, and there appears to be a substantial benefit. And you can see maybe even cures, right? So we're really excited about that. So there are 3 components now of treating a newly diagnosed advanced ovarian cancer patient. Obviously chemotherapy, carboplatin, paclitaxel, almost always given every 3 weeks, almost never given with intraperitoneal, number 1. Number 2, targeted therapy, which can either be bevacizumab with chemotherapy and maintenance, or PARP and maintenance, or both, okay? But the third component, we don't talk enough about it, is the surgical aspect. Surgery is still important. I gotta say though that the impact on sort of the longevity of the patient is greater impact, bigger deal with chemotherapy, and also a bigger deal with targeted therapy. But still, surgery is important. I don't ever mean to minimize it. And these are the sorts of patients that went on PALA-1, sort of their surgical outcomes. And you can see only about half of them had no residual disease. So the question was, is there still a benefit in these sorts of subsets? And obviously there is. Bevacizumab olaparib is indicated regardless of the surgical outcome, and has an improvement in progression-free survival based on the timing of the surgery, whether it's interval or primary debulking, and also improved progression-free survival based on the residual disease. So there are lots of sort of types of patients. Again, it's sort of our responsibility to use the right treatment at the right time in the right patient. But all patients, regardless of surgical outcome, had a clinical benefit based on what Dr. Grimm says. This was a very sophisticated sort of comparison. Can't really do cross-trial comparisons, but the intention was to do what I have already talked about, that in the BRCA mutated groups, what's the best treatment? Bevacizumab olaparib or olaparib alone. And because they both had the same sponsor, they could really share the databases with the study chairs and do the statisticians a sophisticated analysis. And there's no question that in the BRCA mutated group, In my mind, there's no question, even though this is sort of a fancy analysis, that the best opportunity for that patient who's on bevacizumab is, and has a BRCA mutation, is to add olaparib onto it, not to stop the bev. And here you can see that there is a benefit on the upper left of bevacizumab. There is that olaparib is better than bevacizumab in sort of an indirect comparison, but the real opportunity is the combination, which is dramatic, as you see in the lower right-hand corner. And these are confidence intervals surrounding those estimates. So again, May 8th, FDA approved olaparib in combination with bevacizumab for the first-line maintenance treatment of patients with ovarian, tubal, and peritoneal cancer that respond, but only in the HRD subset. They call this genomic instability. That's the FDA's language. Don't get it confused with genetic instability, which is what we call MSI high. It's not what this is. This is very different. And I'll get into sort of the testing in a minute. So this is the other PARP inhibitor trying to add it to bevacizumab in a single-arm study. It's looking good. It was an interim analysis. And then in platinum sensitive, we're trying to do the same thing. This was an NRG study funded by the government as well as the sponsors, but it was a CTEP trial adding the oral anti-VEGF to olaparib and comparing it to chemotherapy. And it did not meet its primary endpoint. So target therapy is not better than chemotherapy. You may say, well, it's almost as good. You can't really draw that conclusion. And so, chemotherapy is still going to be with us, at least in platinum-sensitive relapse, really in all subsets. So we still have what are called treatment indications. Everything that I've talked about were maintenance. You had the 3 recurrent maintenance approvals, and then you have the 3 frontline approvals. Again, olaparib alone, niraparib alone, or olaparib bevacizumab. So you have 6 approvals in maintenance. We also have 3 treatment indications for all PARP inhibitors. I want to highlight some new data for you. One is the quadra indication for niraparib, because again, that's beyond BRCA. The other 2 PARP inhibitors, olaparib and rucaparib, only have BRCA indications, but the quadra indication in October of 19 is beyond BRCA with this HRD molecular signature. Solo 3 was just published. It's interesting because they compared it to chemotherapy, and unlike the energy platinum sensitive comparison, this comparison showed it was better than chemotherapy. So in treatment, in BRCA patients, PARP is better than chemotherapy. And so that's what this did. It compared them, and you can really see the waterfall plot, which is dramatic, and you can also see the statistically significant and clinically important improvements in progression-free survival. So this is a very important study. This is part of the due diligence for the initial accelerated approval in 2014, and mission accomplished. So treatment is a good option in the BRCA patients. Unfortunately, on April 10th, the ASCO group updated their testing guidelines, but we didn't have the PRIMA indication or the PALA-1 indication. So they don't talk about HRD testing. They do talk about tumor testing, and obviously HRD testing is a tumor test, but the ASCO guidelines only talk about somatic BRCA testing, because at the time they were written, the only opportunity was the SOLO-1 indication. I think these are still very important. Obviously, germline testing has to happen and is recommended. And it's not just BRCA, it's a panel, right? Because there are other hereditary breast and ovarian cancer genes beyond BRCA, and it's the same price, it's the same next-gen sequencing analysis. You just don't get the data unless you ask for it. And tumor testing, I think, is now HRD. And I think you should do both. I get it that if the patient has a germline BRCA mutation, maybe you don't need to test the tumor, but that's only in about 15% of patients. So you can be reassured that 85% of patients need both testing. If you want to wait and get the germline first and then do tumor, or you just say, look, there's very little overlap, I'm just going to do both. So this is exactly what I was talking about. This is the HRD tests that are available. There are only two. Don't look for the genetic mutations. You have to look for the genetic scar. And again, there are two. The foundation test, which is not a companion diagnostic except for treatment, and really what they're looking for is a BRCA mutation, not a loss of heterozygosity, HRD. So there's no question that the test that you should order, basically on all patients, is Myriad MyChoice HRD, because that's the companion diagnostic. And it's not the same as the Foundation 1 test, and it's certainly not the same as looking at the genetic mutations, because the genetic mutations are not created equal. So what you really want to know is if there is homologous recombination deficiency, if a PARP inhibitor will work. And the Myriad MyChoice HRD has now been validated in PRIMA, in PALA-1, and in NOVA. So that's the test you should do, and I think you should also do germline panel testing as I outlined. We're not done. I get it. We like bevacizumab olaparib. We like single-agent PARP inhibitors too. But there are so many other combinations, particularly with checkpoint inhibitors. We're very excited about them. This lists them. Basically, you can imagine, the PARP inhibitors that I listed. There are a number of checkpoint inhibitors, and almost all of them are being combined with a PARP inhibitor. So we're very excited about that opportunity. We're also excited about bevacizumab checkpoint inhibitor, right? So maybe PARP doesn't have a role there. So that study particularly, which is called Imagine 50, again, another GOG study, will report this year. So maybe there will be two options with bevacizumab, olaparib and atezolizumab. Stay tuned. That would be a fun conversation to have. So my take is that PARP inhibitors are here to stay. Okay? 4 tumor types: ovarian, breast, pancreatic, and prostate. And in ovarian cancer, we have treatment indications 3, we have recurrent maintenance indications 3, and we have frontline indications 3. And in frontline, you can even use it with bevacizumab in the appropriate biomarker positive subset. So we're excited about that. Testing is important, not only germline, but tumor testing, somatic testing. Myriad MyChoice HRD now is the companion diagnostic for PALA-1. So I'm so excited to share this with you. This is practice changing, and thank you for spending a few minutes with me today, and for your time, and thank you for all of you do to change the patient experience, to help patients live longer and live better. Thank you.
Thank you for listening. Download materials and complete the post-test for instant credit at peerview.com/VSY860. This activity is supported by independent educational grants from AstraZeneca, Merck & Company Incorporated, and Myriad Genetics Incorporated. This activity has been jointly provided by Medical Learning Institute Incorporated and PVI, Peer View Institute for Medical Education.